Hi, I'm Ann Lowe with the Lowdown on Cancer, and this month we've been talking about access to care, and as we've dived a little bit deeper into this, we've found that access to care now, especially since COVID, includes telemedicine or telehealth, and I thought it was best that we speak with somebody, a physician who's actually utilizing telehealth and kind of get a feel for how he feels about it. So today I am incredibly honored and excited to be joined by Dr. Michael Manning. And we're going to talk about this a little bit. Dr. Manning is a double board certified in internal medicine and allergy and immunology. And he's located here in Scottsdale, Arizona. He's active in multiple committees. He's a leader within the industry, and he lectures all over the United States. He also runs a state-of-the-art, cutting-edge research clinic right within his own clinic. And he's been voted the top doc in Phoenix, Arizona for over 20 years, which is no surprise. And not only that, he was probably one of my all-time favorite volunteers in the 17 years that I participated in Little League Baseball here in the state of Arizona. So Dr. Manning, thank you so much for joining us today, because I know you have an incredibly busy schedule. Maybe fill in some gaps that I have there. What's a little bit more about your background?
Well, thank you, Ann, for having me. And I'm honored to participate. And you built me up. I got some high standards now to live up to. No, that's not a nice introduction. Any other gaps is I'm a native of Arizona, born and raised here. And actually, I guess the fun fact about me in medicine is that I joined the practice where I once was a patient. So I used to get allergy shots in our South office. Knew the two physicians there. One of them also took care of my mom. So in high school, I went to him and said, I kind of like medicine. I like law. I was really a science geek. I don't know why law even came up. And I said, what should I do? And he truly loved medicine and pointed me in that direction. And I sent him back, and I think in med school, I had my mom talk to him and said, tell Dr. Hartley to save me a chair, I'll be back. And lo and behold, there was a chair, and I joined. The nurse who used to give me those shots was still working for us for quite some time. So I went from being her patient to being her boss, which that's a weird scenario. So.
Oh, very interesting. So there's so many specialties to pick from. What led you to allergy and immunology?
The immune system was very interesting, fascinating, but I had experience in it. I mean, I had allergies myself. My mom had asthma. I felt comfortable with it. It's a field where you get to know the patients and talk to them, and I couldn't be a surgeon just because though I like doing stuff with my hands, I would much rather just sit and talk to somebody. And our office has had generations of patients. We tend to know them all, and I will talk as much Little League Baseball with a patient as I will medicine or whatever, and that's what I really enjoy. They become like your family. I spend more time here than with my family, so I better enjoy it. And I guess that's what attracted it to me. Dr. Hartley's patients, he walked on water to them and the way he practiced. And so I try to mimic my practice after what I saw him do.
Well, I know a lot of patients that see you, and I think that they all think that you walk on water as well. So I think you've embodied what you were experiencing yourself. So, which I think is a major compliment when people love a physician so much that you actually get voted top doc. So earlier in the month, I interviewed a professional named Dr. Margaret Kierkegaard, and she was talking to us about access to care. And, in looking at access to care, it isn't always about access to insurance. Sometimes it's access to the right care at the right time in the right place. And COVID really threw a wrench in our routine healthcare by making it difficult to get into a doctor's office. And then the insurance companies began to approve paying for telemedicine. Was telemedicine something that you utilized prior to COVID?
We had not. It had been talked about. It had been talked about in our specialty conferences, the academy and the college meeting. It had been brought up. I looked at it as thought, well, this is a platform that's probably more suited to somebody who just only talks, like a psychologist, a psychiatrist. Great platform for that. We want to listen to the lungs. We want to look at rashes. We want to do some other stuff or do some testing. But once this hit, we were kind of thrown into the fire like, okay, now we got to do something. We got to do it quick. It's really been nice. The biggest downfall is when the platform doesn't work and the glitches of just technology. And I thought, it's us, it's our system. And I saw an interview with Bill Gates, who should have the best stuff in the world, right? And his audio and video was off sync and all this kind of stuff. And I thought, you know what? That makes me feel good. If his is having glitches, I'm not going to worry about it. But when you say access to care, and yes, certain conditions need a true subspecialist, and those aren't everywhere. So one of the types of patients we follow is something called hereditary angioedema. Occurs in about 1 in 50,000 people to maybe 1 in 100,000. We think there's about 8,000 people in the US with this condition. Not everybody is an HAE expert. And if you're living in a remote area, having access to an expert, and we've done a lot of research in it, and there's a group in California and some other places that can help manage and at least talk through it, talk to you, see you, and then get you back to your primary care physician with the proper instructions. They can do the day-to-day work, but they can tap into us without flying anywhere, without driving anywhere, and we can talk to them, see what's going on, visually see them, and certain things you can see on camera if you're having a reaction. So I think it's opened that up. We've got patients that are in Lake Havasu City and Flagstaff and Prescott and Payson and these places. Recently, we've been doing a lot of their routine follow-ups via this just because, but it's something we will utilize going forward, because why have them drive 4 hours from Lake Havasu for something that's routine? If it's different, okay, fine. But if it's the routine stuff and we don't need to do a complete physical examination, we worry about the environment. And there's a lot of rules with insurance. You can't do certain things at the same time on the same day. And so there's things, if they're seeing me, they can't do anyway. It's like, well, that's kind of stupid to, make somebody drive again and increase their carbon footprint if we're worried about this. So if they don't have to drive 8 hours, gas, et cetera, then why not? It's better for the environment in that sense too. So there's a lot of advantages.
Yeah, and that's kind of my experience too in talking to a lot of physicians, in the last 2 or 3 months, is that, it seemed like there were 3 camps. There were the people, and they still kind of exist this way. There's people that hate it. There are physicians that love it. And then kind of like you, they recognize that there is a place for it. And so from what I'm hearing, you're saying that this is something that you would keep utilizing in your practice moving forward.
Oh, absolutely. Pandora's box has been opened with this. It will not shut. So I see us keeping it in place. Whether we keep the same platform that we're using or not, we're using a HIPAA compliant platform that a lot of people signed up with. And there was a lot of issues initially because they were signing up thousands of physicians a day, an hour, and the system, the infrastructure wasn't really there. Hopefully that gets better over time too. So yeah. We will keep it and if it's something easy, we can check in. It's a great way to do it, even on the weekends. Somebody calls me up and says, I'm having a reaction. Before I'd pick up the phone and talk to them on the weekend, and you're kind of saying, okay, I wish I could see it, right? Now I could say, hey, let me send you a link. Let's sign you up for this. Let me send you a link and I can look at you, right? Or there are times when people would have an allergic reaction and the information was, okay, if you use your epinephrine and you're having a food reaction, you got to go to the ER because we want somebody monitoring you, which, okay, I firmly agree with that, but not everybody needs to. And if I could be on a video conference with them after a reaction, they've used their epinephrine, and I'm sitting there for maybe 30 minutes, whatever, monitoring them, and I can really get a true sense of what's going on. I can say, I think this is good. Let's stay there. Don't go to the ER. Don't use those resources if you don't need them. Let's stay home. You can call me back later if you need be. So I think it has a tremendous upside. It's just, you know, when people hate it, I don't know if it's just hating technology. The only time I hate it is when it doesn't work. Then I'm frustrated. Then I pick up the phone and call them, and you know, we're done with the video part of it. But that's the only time I hate it. Otherwise, I think it's great.
You know, you spoke to something that I hadn't even really thought about is, you know, decreasing the carbon footprint. And actually, I would think as a physician where you often have to come into the practice on a weekend or that kind of stuff, that must save a lot of time for you.
Absolutely. It frees up. Sometimes in an office, we may get even room locked because we're doing multiple procedures and it ties up the rooms, and you want to do more procedures, but you can't. Procedures that may take several hours of like a food, for us, a food challenge. And I really have to speak to my profession or my specialty because that's what I know. And so it ties up rooms, and it's now I can be having a visit with another patient online while I've got my room tied up with a food challenge, and they overlap nicely versus that patient waiting out in the lobby because we had an unexpected, you know, issue come up and now we don't have a room for them. So it helps free up and helps free up space. And I think it helps kind of the workflow, patient flow. I think it allows patients to be more productive if they don't have to leave work, and they can do it from work if they feel comfortable doing it from home, and they don't have to find a babysitter, or they don't have to drag all 8 kids with them down here kicking and screaming for her appointment or one child's appointment. You know, I think there's a lot of advantages. And like I say, it's not going to replace every visit. It just can't, you know, but it sure does supplement it nicely.
So Arizona was a state that locked down, and, you know, we kind of sheltered, and a lot of the, you know, the hospitals chose not to do elective procedures. When COVID first started happening, were you still seeing patients live, or was everything through telehealth or telemedicine?
No, we were still seeing patients live, and I feel you cannot not do that. I mean, that's what we signed up for. That's what I got into the profession. I mean, if somebody's sick or needs me, I'm not going to run and hide and say, you know, gosh, I can't because there's this virus. I mean, we're going to do everything we can to keep the patient safe, our staff safe, our office safe. And so we put all that in place. And I think if you're smart, you can get through this. I mean, I was in medicine when the HIV epidemic hit, and talk about something that nobody knew anything about, and that everybody died. There was not a question. You got this. It was a death sentence back then, and made the rest of us working around them nervous, but we still did because that's what we were supposed to do, right? So we're still seeing patients live because sometimes you got to listen to the chest. We were being careful about screening, which I think you should. If somebody really, and it's just like the flu. If somebody calls me up and I go, wow, they got influenza, I'm not making them come into the office and be a spreader and get a whole bunch of people sick. It's like, no, you got the flu, you know, call them in a prescription, stay home, let me know if it's not changing. So I think there's things we should always do that with. In the same way with this, if somebody was, you know, called up and wanted to be seen and they had a significant cough that was recent and running a high fever, we would do a telehealth visit for them to try to get a sense of what's going on. If we needed to bring them in, then we would. We changed some of our procedures in the office from breathing tests because, you know, breathing test or breathing treatment is a big aerosolization issue. So we needed to comment on that. And so the academy and the college also, you know, told us to kind of damp down with that. So there were some procedural changes, but we've been seeing patients live from the get-go.
So I, you know, have had some telemedicine appointments, and when they were first proposed to me, I really didn't want to do that. You know, I like to be in person. I like to see my physician face to face. But interestingly enough, my attitude on that changed. Did it feel like you had patients that were reluctant that now they seem to like it, or what kind of feedback have you gotten?
We've gotten both. There are some patients that still just want to come in, and they will still come in. They want to be there. They want you to listen to their lungs. They want you to look at something, and that's, you know, perfect. By doing more telehealth or doing a combination, it keeps our lobby not as crowded. So that helps increase safety and social distancing, and people can spread out. And so there's an advantage there. A lot of patients like it. And some like the ability to do both. I can have a telehealth visit, or if I need to come in and be seen, I can come in and be seen. So there's not been a ton of pushback.
Now, you shared a great story about seeing somebody who needed some urgent care.
I did have one patient that thought he was having some allergy symptoms and some swelling, and thought he had one of these, unique forms of swelling like hereditary angioedema. And his signal wasn't working, so I was on the phone, and finally he went to a different part of the house, and everything kind of came up. And I looked at him and said, "You're not having swelling. I think you're having a stroke, and I need you to go to the hospital right now." And he was having a stroke.
Wow.
And it was still early on, so I think they were able to turn it around. He had no allergy issues whatsoever, but until I saw him and saw one side of his face not working, which he was not describing to us at all, um, that visual input, and it doesn't have to be across the table or, sitting on a table with me in a chair. If I can do it this way, we got him off, and I said, "I know nobody wants to go to the hospital right now. You have to go to the hospital. There's no ifs, ands, or buts on this." So, he left within probably a minute of me telling him that, or had somebody drive him, and away he went. That was the most dramatic. I kind of walked out of that visit going, that was kind of cool, because I got him to where he needed to go right away. Versus if he'd come into my office and we saw him, we would have then said, "Okay, we got to call an ambulance to get you over," and we would have done the same thing. But we were able to take care of it.
That's amazing. That's an incredible story. Have you heard any other experiences where it has helped people get diagnosed earlier than what they might have been, had they actually had to wait for a traditional appointment?
Not from my standpoint. I'm sorry, I don't have a good story on that. Just because most of those types of things, you need to actually be looking or listening or seeing up front on that kind of stuff. It may allow somebody who is remote that may not be able to come in or take off work that we can listen to and really get a good history on and say, I think this is what's going on, and we can address it, where they may have said, "Well, I don't have time off. It's going to take me a couple of weeks to be able to get somebody to cover my shift," or something like that, and we can get them going. So we've done that with a few things, mainly respiratory stuff and asthma, and we've got them on the right inhalers, the right medicines, and listen to them. You can kind of hear them wheezing, and you can kind of watch their breathing pattern and stuff on a video call. That you can hear some of that on a phone, but it's not quite the same.
Right. Yeah, I can actually see that. Although it seems like telemedicine now has a place in healthcare, in my opinion, I believe that there are some gaps in viability. And because we speak to innovators as well as patients, what kind of innovations would you like to see that you think could be an advantage to utilizing telemedicine?
Innovation, some form of a 3D camera. Because then you can appreciate something that is truly swollen, raised, texture, maybe a little bit better than a 2D frame like we're looking at. Yeah, you can still see a rash, and there's a lump there, but really, is it swollen? If you can, then you move your arm and you take it at a different angle, you may be able to see some swelling. With a 3D camera, if there's some form of that, would I think be very beneficial. Monitors, we can have people that have an O2 sat at home, and they can check their blood oxygen level, and some things like that would be helpful just for some simple things. Or if we can somehow plug in some of the smartwatches that actually do a tracing, and they can do an electronic, ECG tracing, and for a cardiologist, they could monitor some things like that. For us, if there's ways to innovate and listen to breath sounds, that would be helpful. Now, if there is a technology that could kind of listen in and transcribe it as we're talking, but also not do it. I don't know if you've ever read a deposition. Have you ever read it? Oh, it's brutal, right? And you go, people talk like this? Well, it's because when we're talking, we're not talking with punctuation and complete sentences. And somebody transcribing a deposition, it's just verbatim. They can't change it. Well, if you had artificial intelligence that could sense that sentence and complete it, put the right punctuation or whatever, or highlight it, and you could go in later and fix it up a little bit, would be nice. So things like that would be very helpful.
I think anything that we can do to make it easier to be seen, And again, like I say, get to see the front side of a doctor instead of the backside is so much more useful. Dr. Manning, I just want to thank you so much for joining us today, really giving us some insight about the value that this can be with your own practice as well as other people's practices, letting patients know about why it can be beneficial for them. And I just want to thank you because I do know how busy you are. And I just want to thank you for taking the time to sit with us today.
Oh, well, thank you very much. I was honored to be a part of this. So thank you.
Thank you for watching the Lowdown on Cancer presented by the Cancer Fund. To learn more about what's coming in future episodes, visit us at www.cancerfund.com. While you're there, check out past episodes and be sure to click Join Us to become a member of the Cancer Fund community. As a member of the community, you'll receive early access to new interviews as well as other announcements. Make sure to connect to all of our social media channels so you don't miss a thing. In addition to getting early access to new episodes of the Lowdown on Cancer, Cancer Fund members play a critical role in driving cancer innovation forward so that one day we can more than hope. We can actually beat cancer. Thank you for joining us on this journey.